Thank you very much. And it is a pleasure here to present and share my experience of interventions in heart failure management. It was a pleasure hearing Dr. A.B. Mehta, and he's looking as young as he was 20, 30 years back since I'm seeing him. So, congratulations to you, and hope to see you like this again and again.
Thank you.
So, I will start my presentation now on the interventions in heart failure management. And of course, we have been doing interventions in patients in stable situations to start with, but now increasingly more complex patients. Basically, as we know that, we have been doing interventions for the last so many years. And initially we started with the, patients who were relatively stable. But now we have situations, as you can see here, where the coronary artery disease is presenting with low ejection fraction, acute myocardial infarction with cardiogenic shock, ischemic cardiomyopathy, severe aortic stenosis coming in heart failure, severe mitral regurgitation coming in heart failure, and sometimes even both the valves, severe MR and severe TR. So do we have interventional options for them? So now today, I'm going to present to you some of these cases which we have done and found good results in these patients where intervention was helpful and surgery was very, very high risk. The scores were above 10% and the mortality expectation was more than 50% if surgery was to be done. So these are the potential situations where we were struggling initially to save patients and to improve quality of life. We have these new drugs, of course, and a lot of discussion will be happening and must be happening now on the new drugs, but now we have new devices. And one of the new devices for interventional treatment where we do this mechanical circulatory support is Impella and ECMO. The second is doing TAVR in severe aortic stenosis patients, then doing MitraClip in severe mitral regurgitation in patients with low ejection fraction and who have high risk for surgery, valve-in-valve implantation for previous failed bioprosthetic valve. In these patients, when there is a mitral valve which is failing, we can do a procedure known as transcatheter mitral valve replacement, which is known as TMVR. So to start with, let me start with the Impella of Dr. Mehta already told us a little bit about that. Then it is a micro pump which goes inside the heart, and patients in heart failure and severe CAD, we can do these interventions. So out of my experience of angioplasty and TAVR and TMVR and paravalvular leak closures in these high risk patients, where in some patients we even did double valve replacement doing TMVR and TTVR at the same time. So a lot of possibilities have come up, and out of these patients, as you see, around 10% of total patients which we do interventions are low EF patients, and some are very, very low ejection fraction. And to add to the whole problem, many of these patients are elderly, they are post-bypass, and so on and so forth. So this is why the problems are compounded, but we have solutions now which we can offer. So the first solution is that we do these procedures, and this procedure is known as protected PCI, where if the coronary anatomy is complex, the patient has hemodynamic compromise, they are advanced age, renal dysfunction, post-bypass surgery patients, we can do this. And in these patients, we can improve ejection fraction, reduce acute kidney injury and heart failure by doing interventions with the help of this support device known as Impella. And it works by unloading the left ventricle, improving the coronary perfusion during intervention. End organ perfusion is improved. There is a support for right ventricle, which is also possible now, and early ambulation and escalation of treatment can be done to these patients. So this has been shown in, even in the nuclear scans, that once we do this unloading of the ventricle, there is improvement in perfusion and coronary flow velocity with subsequent improvement in ejection fraction over even days. Up to 28 days, we have seen improvements after this therapy where ejection fraction improved. And reduction of blood concentrate concentration in cardiogenic shock patients happens very rapidly when we do this end organ perfusion with mechanical circulatory support using Impella. And it improves to get good results in protected PCI, where there is reduction in MACE about 29%, and more complete revascularization can be done, lower rates of acute kidney injury, and you can see how the hemodynamic changes if you use these devices. So I'm quickly, going to a case now, and this is a patient who was a post-bypass surgery patient recently, and his surgery failed. His ejection fraction was 25%. He was put on intra-aortic balloon in the emergency. Noradrenaline support was started, and then when we started thinking of doing intervention, it was very difficult. So we immediately thought of doing this intervention on Impella, which was very helpful in this patient. And here you can see the anatomy is so bad, the bypass has failed, and we have to do this intervention because there is no other way, and the patient is so sick, ejection fraction is so low, and the surgeons have put their hands up saying nothing can be done from their side. So what do? So we still have to help and try to revive this patient. And let me tell you, we did this intervention with Impella, which you can see now in this picture. And we are doing dilatations of the left main and circumflex. Everything is being done at the same time. And we got a good result with this patient, and this patient really did well. And the patient is still alive. This is about 3 years now. So another patient, low ejection fraction, like 20%. And he's needing a AICD for his arrhythmias, and low. You can see that the Impella is put in to treat this very complex anatomy, and multiple stents were implanted from the left main to LED circumflex, and that's how we could do. So today, PCI or intervention can be done in low ejection fraction patients, heart failure patients, with the help of mechanical circulatory support, and Impella is one of the main devices right now. Now we move on to the valve problems, where patients come with low ejection fraction and severe aortic stenosis. And here these are very common today. Most of these patients are above the age of 70 years. So what do? So this is a typical patient where we did this intervention with a self-expanding valve here, and you can see that after the valve was implanted, his gradient came down. In the patient with low ejection fraction, where surgery was absolutely impossible. So this is all possible sometimes without support, and sometimes we need hemodynamic support, like tandem heart, like Impella, like ECMO, as Dr. Mehta already showed to us. All these can be used while even if the patient is undergoing CPR. We have done these procedures, and one of these procedures is this is a patient who 20% ejection fraction, post bypass surgery, and severe aortic stenosis. What do? So this patient, the patient was put on, because he was having VT, so he was put on a cardiopulmonary support by ECMO, and you can see that the patient is having continuous VT. He was ECMOtized, and we proceeded with TAVR in this patient. Gradually, the patient stabilized. This is the TAVR which is being done in this patient. You can see that the cannulas, and this is the valve which is being implanted, and we got a very good result in this patient, and this patient also survived. So possibilities are improving day by day. Now, if you can see, again, 30% ejection fraction, severe aortic stenosis, risk is very high, and the STS risk scoring was done. High mortality was expected, and this is a very bad valve, low ejection fraction. Patient was inoperable, and we see bicuspid valve, and we could implant a self-expanding valve. This patient did well, and then again he developed some regurgitation, for which he was again brought back, and we did a valve-in-valve from the subclavian approach because his vessels were also bad, and we went from the subclavian side. You can see the valves which are moving around in the heart, and they're all doing fine. Then the third possibility is severe mitral regurgitation treatment in low ejection fraction patients, and in these patients, when sometimes even they come in cardiogenic shock. So this is the extreme end of this, of say mitral clip patients, and this patient was put on a balloon pump. He was not improving with balloon pump for 10 days. So he was taken for a mitral clip implantation. And this patient, I think we did about 7-8 months back. And this is the clip. You can see the clip which is been implanted. And this patient has exhausted all the options. He has a biventricular device. He has severe MR. He has cardiogenic shock, whatnot. And here, this is the echo, which is a very low EF. And severe mitral regurgitation, you can see. Very, very extreme mitral regurgitation, torrential. And after the clip, you can see that the regurgitation has started decreasing in this view. You can see the clip is in position, and once the clip was there, the mitral regurgitation immediately reduced, and the role of 3D prime transesophageal echo is immense in treating these patients while we are taking them up for such procedures. So I think, in heart failure, we still are struggling to save patient and improve their quality of life, but new hopes have come up. And the hopes are for intervention. We have Impella, we have ECMO, we have mechanical circulatory support assisted PCI. Then doing TAVRs in these patients improves quality of life and also quantity. Mitra clip for severe mitral regurgitation and low ejection fraction. TMVR, which is transcatheter mitral valve replacement in bioprosthetic heart failure, is another dimension which we have now practiced quite commonly. And I think in our hospital, the choice of procedure for a failed bioprosthetic valve is a valve-in-valve percutaneous. And then we have done transcatheter mitral valve replacement and transcatheter tricuspid valve replacement, both together in the same patient at the same time, and has really given adverse results. And the last procedure which we do again very commonly, again in post-bypass patients, is a PVL closure, a paravalvular leak closure, again a percutaneous procedure in low ejection fraction patients who are leaking valves from the side. And this procedure is very straightforward, nice, and patients can be discharged on the very second day. So with this, I think I will stop here. This was a snapshot of what we can do today in low EF patients by interventions. Thank you very much.